Introduction. Welcome to today's lesson on orbital cellulitis. In this session, we will explore the various aspects of this infection, including its causes, anatomy of the orbit, microbiology, pathophysiology, clinical presentation, differential diagnosis, diagnostic workup, medical management, complications, periorbital versus orbital cellulitis, imaging modalities, and surgical interventions. By the end of this lecture, you will have a comprehensive understanding of orbital cellulitis and its management. Orbital cellulitis is an infectious condition characterized by inflammation of the tissues within the orbit. It is commonly caused by the spread of an infection from adjacent structures, such as the sinuses or eyelids. The most common pathogens involved in orbital cellulitis are Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenza, and Streptococcus pyogenes. However, the causative organisms may vary depending on age, immunization status, and local microbial flora. To comprehend the pathogenesis of orbital cellulitis, it is crucial to have a thorough understanding of the anatomy of the orbit. The orbit is a complex structure consisting of bones, muscles, nerves, blood vessels, and fat. The globe is surrounded by three layers: the orbital septum, the muscular cone, and the periorbital. Infections originating from the paranasal sinuses or eyelids can easily spread to the orbit due to the anatomical proximity and communication between these structures. The most common pathogens involved in orbital cellulitis are bacteria, particularly Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenza, and Streptococcus pyogenes. These organisms tend to colonize the respiratory tract and can disseminate to the orbit in cases of sinusitis or preseptal cellulitis. Additionally, fungal infections, such as Aspergillus and Mucor, can also cause orbital cellulitis, albeit less frequently. The pathophysiology of orbital cellulitis involves the invasion of bacteria into the orbit, triggering an inflammatory response. This invasion can occur through direct extension from adjacent structures, hematogenous spread, or via the lymphatic system. The infection leads to edema, inflammation, and tissue destruction within the orbit, which can result in a variety of complications if not promptly treated. Recognizing the clinical presentation of orbital cellulitis is essential for timely diagnosis and management. Patients with orbital cellulitis typically present with signs and symptoms such as periorbital erythema, swelling, pain, proptosis, ophthalmoplegia, and impaired vision. Systemic manifestations, such as fever, malaise, and headache, may also be present. It is crucial to differentiate orbital cellulitis from other conditions that can mimic its clinical presentation. Several conditions can mimic the clinical presentation of orbital cellulitis, making a precise differential diagnosis crucial. These conditions include preseptal cellulitis, allergic reactions, neoplasms, cavernous sinus thrombosis, and Graves' ophthalmopathy. Differentiating between these entities is crucial, as their management and prognosis can significantly differ from that of orbital cellulitis. The diagnostic workup for suspected orbital cellulitis involves a combination of imaging studies and laboratory tests. Imaging modalities such as computed tomography, CT, scan and magnetic resonance imaging, MRI, can provide detailed information regarding the extent of infection, abscess formation, and involvement of critical structures. Laboratory tests, including complete blood count, blood cultures, and inflammatory markers, can aid in assessing the severity of the infection and guiding treatment decisions. The cornerstone of medical management for orbital cellulitis is antibiotic therapy. Empirical broad-spectrum antibiotics should be initiated promptly based on the likely pathogens involved. Intravenous antibiotics are usually required initially, followed by a switch to oral agents once the patient shows improvement. Surgical intervention may be necessary in cases of abscess formation, orbital compartment syndrome, or failure to respond to medical therapy. Orbital cellulitis can lead to various complications, including abscess formation, cavernous sinus thrombosis, and vision loss. Abscesses may require drainage to prevent further spread of infection and relieve pressure within the orbit. Cavernous sinus thrombosis is a life-threatening complication that can result in septicemia and cranial nerve palsies. Additionally, prolonged or severe inflammation can lead to optic nerve compromise and permanent visual impairment. Distinguishing between periorbital and orbital cellulitis is crucial, as their clinical features and management differ significantly. Periorbital cellulitis refers to infection and inflammation of the eyelids and surrounding skin, whereas orbital cellulitis involves deeper tissues within the orbit. Clinical features such as the presence of pain, ophthalmoplegia, proptosis, and impaired vision help differentiate between these two conditions. Periorbital cellulitis can often be managed with oral antibiotics, while orbital cellulitis typically requires hospitalization and intravenous antibiotics. Imaging plays a pivotal role in the diagnosis and management of orbital cellulitis. Computed tomography, CT, scan is highly valuable as it provides detailed information regarding the extent of infection, bone destruction, and orbital abscesses. Magnetic resonance imaging, MRI, is particularly useful for assessing intracranial and optic nerve involvement. It is important to consider the advantages and limitations of these imaging modalities to make appropriate diagnostic and therapeutic decisions. Surgical interventions may be necessary in cases of orbital cellulitis with complications or failure to respond to initial management. Abscess drainage, orbital decompression, and endoscopic sinus surgery are among the surgical approaches employed, tailored to the individual patient's needs. The decision to proceed with surgery depends on the severity of the infection, presence of abscesses or complications, and clinical response to medical therapy. To conclude, orbital cellulitis is a serious infection of the orbit that requires a comprehensive understanding of its causes, symptoms, diagnosis, and treatment options. By familiarizing ourselves with these aspects, we can provide better care and prevent complications.